point, that's it, perfect.
Great, thank you very much for asking me to speak, Atul. Sorry about that. You've asked me to speak about chest deformity. I'm not a cardiothoracic surgeon, I'm not a spinal surgeon, so this is going to be a whistle-stop journey through the eyes of a paediatric respiratory consultant. All of us working in tertiary respiratory hospitals see a lot of children with chest deformities. I'd like to concentrate on pectus deformity, but also scoliosis, as that's very much something we get involved with, and also some of the more unusual thoracic insufficiency syndromes. Pectus excavatum we'll start with. This is one of the most common, probably the most common presentation that we see. This is a funnel-shaped chest because the body of the sternum is displaced posteriorly. It can be, it's usually symmetrical, but can be unilateral, can be asymmetrical, like in figure C there. It's familial, it's fairly common, 1 in 400 live births. The inheritance is unresolved, the pathogenesis is also poorly understood, but there are abnormal costochondral joints. It's usually isolated, but it may be associated with collagen disorders, particularly Marfan syndrome, Ehlers-Danlos syndrome. We also see it with underlying lung disease, particularly pulmonary hyperplasia, and it may also be one element of a more complex chest wall deformity. What are the physiological effects of pectus excavatum? Well, the major complaint is cosmetic. If you look, there is decreased exercisability, there is decreased cardiovascular function and lower lung volumes compared to age and size matched controls, but those effects are very small, often mild, and these kids fall probably within the lower range of normal. In severe pectus excavatum, the heart can be displaced to the left. That can impair right ventricular filling and give reduced cardiac output, usually at maximal exercise. But the real effect on exercisability probably isn't the lung volumes, probably isn't the cardiac output. It's probably lack of fitness or deconditioning through avoidance of exercise from embarrassment from the appearance of the chest. What to look out for? Look out for signs of Marfan syndrome. You may have a Marfan's clinic. That's usually run by the cardiologists. Listen for murmurs, mitral valve prolapse, aortic regurgitation, and look for scoliosis just to make sure this isn't part of a more complex thoracic problem. You can do pulmonary function testing, exercise testing, echo if there's a murmur present, an X-ray, and a CT if you're contemplating surgery. Here's an X-ray of a child with pectus excavatum. I'm always impressed by the radiologists who can tell me that from an X-ray. What looks to me like perihilar inflammatory change is actually the costal cartilages. That blurring of the right heart border is the costal cartilages. Here also, something I might call perihilar bronchial wall thickening. So very interesting. Here is a fairly severe unilateral pectus excavatum, just demonstrating some compromise to the heart, as you may see. Another cross-sectional CT showing the Haller index, which is a simple measure, objective measure of severity of pectus excavatum. You've got a maximum transverse diameter over the minimum AP distance. What does that mean? Well, how do we manage pectus excavatum? No treatment is a very reasonable option, and decision for surgery is largely made on cosmetic grounds. Obviously, there are some restrictive and obstructive lung disease patients. There are some patients with cardiac compression, but the majority is cosmetic. Now, the Haller index greater than 3.2 is the objective threshold above which you can consider surgery. But there's no correlation between the Haller index and body image, and there's also no correlation between the Haller index and perceived ability of exercise before surgery. So really, it becomes a subjective decision. Pectus excavatum surgery started in the 1920s with Saulbruch, and he did an incision, resection of costal cartilages, a sternal osteotomy, and he required external fixation for 6 months. There were modifications across the 20th century, but the name that sticks is Ravitch, who in 1947 had a radical mobilization of sternum in his surgery in an attempt to prevent the need for external fixation. So he released the intercostal muscles, he released the diaphragm, and he released the rectus sheath so that sternum would not get pulled back. However, this is pretty brutal surgery. There was a lot of recurrence. And so since then, there's been lots of modified approaches. The modified Ravitch procedure is still what it's called. And from the 1960s, there was a strut put in, or the Atkins strut, as you can see here, to internally fix the sternum. And more recently, they've started using Prolene mesh beneath the sternum to fix it in place. And I think the procedures have become less brutal and more tolerant, but across the last 20 or 30 years, there has been an impression in pediatricians that this is fairly brutal surgery. And of course, it's important, isn't it? Because we are the gatekeepers in a way to this surgery. It's important that we understand exactly what's going on. So I thought I'd just spend a little bit of time going through some quite nice diagrams I found for the procedure. This is the modified Ravitch. So first of all, you open and identify the costal cartilages. Then those are divided, costal cartilages are removed, but the perichondrial space is preserved, and so are the osteochondrial junctions. So the space is still preserved, just that abnormal cartilage removed. You then divide the sternum at the xiphoid process, and you pull the sternum anterior away from the pleural and pericardial membranes beneath. Then you do a wedge osteotomy superiorly on the sternum, and you can see why that's done. You can see if you take the wedge osteotomy, you can then pull the body of the sternum forward and fix the excavatum. And then in this picture, there's a sternal fixation with a pectus bar, but there could be a mesh just as well. The alternative to the modified Ravitch for pectus excavatum is the Nuss procedure, which is termed the minimally invasive repair of pectus excavatum. And this places a bar under the sternum using thoracoscopic guidance. It's not that minimally invasive when you start to look at it. So here are the equivalent pictures for this procedure. The thoracoscope is put into usually the right pleural space, and selective intubation of the left lung is often used. Then two subcutaneous tunnels above the rib cage are managed through blunt dissection to those points X, just in the parasternal region on both sides. Then there's an introducer inserted through through the right tunnel, and actually a pneumothorax is produced by that introducer as it reaches the lateral side of the sternum. This is then the hardest part. That introducer then has to find the plane superior to the pleural and pericardial membranes just behind the sternum, and that's done with thoracoscopic video guidance. And they make it through to the other side. You can see it's in very close proximity to all those mediastinal structures. It's sometimes hard to get that through, and they need to use a maneuver to raise or leverage the sternum up while they're doing this. And this can be done with a vacuum bell on the left, or it can be done with a suture and a crane on the right. And then when they get that introducer through, it's quite flexible, and then they have a chance to shape the chest manually to get it how they want to look at it before putting on an umbilical tape, attaching the bar, and then pulling it back through. And this is done in two approaches. The first approach is with the belly of the bar up as it goes to the retrosternum, and then it's flipped so it's belly down to get through the rest of the anterior chest. So you're going outside the ribs, but behind the sternum. Once the bar is through, they rotate it so it remains belly up. Fixating is extremely important, as it can be displaced quite easily with movement. They then stitch up, stick a drain in to manage the pneumothorax, and they're done. This is what it looks like. Once you've got it, you've got to lie on your back without moving for 6 weeks. So this is problematic for children, obviously. The rod stays in for 2 to 4 years. There's a 5% recurrence rate, but it is very effective in adults. So for us, there's no time pressure in adolescents to have surgery before growth is complete. It can be done once growth is finished. Complications are pneumothorax, wound infection, and bar displacement, 1 in 20, and rarely severe bleeding, and very, very rarely death. Cosmetic outcome reported at 80% good outcome. Exercisability and cardiovascular function do improve in a small amount. Lung function may improve if your vital capacity pre-op was less than 70%. But in teenagers in a Danish study with vital capacity normal range, they had no increase in vital capacity with this procedure. There's a theoretical advantage in doing this in young children as alveolar growth continues into teenage years, and so a surgery would potentially allow that. But surgery has never been offered to children under 6 years because bar displacement is much more likely in children that can't keep still. So I think in considering those two, it's important to understand the procedures. As I say, we are the gatekeepers. We help them make the decision as to whether surgery is appropriate, and it's a subjective decision. Moving on to pectus carinatum, this is where the sternum is prominent and the anterior chest wall is prominent. There are two main types, the chondrogladiolar and the costomanubrial, depending on which element of the sternum is most prominent, whether it be the xiphisternum or the manubriosternal joint. This is less common. It's usually apparent from birth and it may worsen in adolescence. There are little physiological effects to this, so lung volumes and exercise are unaffected. It is again a cosmetic problem, although it can cause pain and some exercise-induced dyspnea. And there may be some underlying disease. We've seen neonates and infants who are persistently tachypneic develop this sort of chest. We see it in air trapping with asthma and CF, also neuromuscular disease and thoracic dystrophies and scoliosis. So it may be part of a more complex thoracic dystrophy. And it can also occur in the collagen disorders. You can't do the NUS procedure for this, so we're back to the Ravitch procedure. It's modified again, but in particular, it's the sternal wedge osteotomies that are different, as the ambition will be to try and get those sternum straight. And so whereas before we saw one wedge osteotomy for pectus excavatum, there may be several wedge osteotomies to get that sternum straight. Clinical commissioning, NHS England in 2019. Although there's a massive tick on the front of the document, there's a massive cross actually. They've decided not to commission any surgery for pectus deformity in children and adults. In Wales, we can still do it, and it's still going on, although the numbers are small. So what can you do if you can't do surgery? Well, pectus excavatum, 2 hours twice a day with the vacuum bell. We've already seen the vacuum bell as part of the NUS procedure. It can also be used every day as a treatment for pectus excavatum. The largest series comes from Switzerland in the Haker group. They've recruited sequentially from 2006, and in a paper looking at 133 patients who used the vacuum bell for 2 hours a day for 3 months, they saw an increase in the sternal elevation by more than a centimetre in 80%. So it does work. A CT confirms that effect, and the best outcomes are in those that are younger, have milder forms of pectus excavatum and symmetrical pectus excavatum and a more compliant chest wall. But there's very little evidence to date of permanence of correction. Does it actually fix it? Because all of these patients in the Haker series, they're still using it. So who knows whether you stop it, whether you've actually corrected the problem. Going now to pectus carinatum, the compressive orthotic brace, or the pectus brace. I think there's more evidence for this. First described more than 20 years ago, a good case series in 2006 from Cincinnati, and this is first-line therapy in many centres. And I think King's are leading, and Birmingham, they both published on it in the UK. You wear the brace for 14 hours a day for 2 years. It's ideal for cartilage that's still pliable, so age 11 or 12 is the ideal age, but there has been success up to the age of 16. Most patients wear it all day and remove it at night. Most improvement occurs within the first year, little added benefit after 18 months. You've got to be pretty motivated to use either the bell or the pectus brace, and your success will be in how much you use it. But these are non-surgical alternatives to the pectus chest deformities. So here's the pectus brace example before and after. I think there is more evidence for the pectus brace for pectus carinatum, for there to be correction, permanent correction of the problem over time. Moving on to scoliosis now. We see a lot of scoliosis in pediatric respiratory medicine. There are different types. We see the idiopathic adolescent scoliosis infrequently because they're well children, but we see a lot of neuromuscular scoliosis and neurodisability scoliosis, and then we can also see some associated with collagen disorders and more complex congenital scoliosis syndromes, either part of a complex thoracic dystrophy or some of the thoracic insufficiency syndromes. Scoliosis is measured using the Cobb angle. This is the angle between the two vertebrae that point maximally towards each other. Adolescent scoliosis, I'll just quickly go over. This is a structural lateral curvature to the spine that occurs near the onset of puberty, and there's no cause present. It gives back pain, feeling of self-consciousness, and it's often asymptomatic. You can get restrictive lung function if the Cobb angle is greater than 60 degrees. If it's under 20 degrees, you don't need treatment. 20 to 40, there's an intervention with bracing that can be effective, but you need to use it 24/7 for 3 years. So again, motivation is important. If the Cobb angle is above 45 or 50 degrees, then that requires surgery. The benefits of surgery are it reduces back pain in your adult life. There's a cosmetic improvement. There's probably no effect on lung function, although I've put an asterisk by that, and I'll revisit that in a minute. Surgical approach, this occurs when the growth is almost complete, and they use Risser staging to identify when that time is. Risser staging looks at the degree of ossification of the iliac crest apophysis, and that's a good guide to the stage of spinal growth. The surgery is spinal fusion with an iliac crest autograft. The spinal rods are there to hold the spine straight while the fusion becomes secure, but they're actually rarely removed once it is secure. Here's some interesting data from Edinburgh looking at the degree of kyphosis that you get with a scoliosis, something that's often ignored by the spinal surgeons who are just using the Cobb angle on the scoliosis. If you look at column C, that's the normal physiological kyphosis that we all have. And when you get scoliosis, you can have that, or you can have a hyperkyphosis, or you can have a relative lordosis, which is in column B. And if you look at this great data from James Farrell up in Edinburgh, this shows you the normalized distance between the spine and the airway. And if you look at the right side, the bronchus intermedius is in very close proximity to the spine in the lordotic scoliosis. If we look now at a specific patient, and this shows the juxtaposition of the spine with a lordotic scoliosis, the airway in green and the right pulmonary artery in blue, you can see that the bronchus intermedius is slit-like in its compression. And so these patients do get a drop in their vital capacity from obstructive, from an obstructive or taking out of the apical segment of the right lower lobe. And so they get actually quite a significant increase in their lung function. Specifically, this group get an increase in lung function with scoliosis surgery if the lordosis is corrected. So this is something that if you talk to your spinal surgeons, they probably won't be interested in correcting the lordosis. They're more interested in correcting the scoliosis, but it's an important subgroup because they get 15-20% increase in vital capacity as a consequence. Looking at neuromuscular scoliosis now, we've probably got two major groups that we look after, the SMA2s and the Duchenne muscular dystrophy, and they're interesting in their life events. SMA2 get a lot of respiratory infection early in life. They get spinal surgery early during the time when their spine is growing, whereas Duchenne muscular dystrophy tend to get their spinal surgery in adolescent years when their spine is pretty much grown. So this has issue that neuromuscular scoliosis and spinal surgery is a big life event. There are comorbidities that make it difficult for the chest: muscle weakness, poor cough and secretion management, and aspiration lung disease. Bracing is an option, but really doesn't decelerate the progress of scoliosis, and shouldn't really be worn in children who have nighttime hyperventilation. Surgery is the major undertaking, especially for children who are young and have a growing spine because spinal fusion needs to be avoided. So they need growing rods or magnetically controlled growing rods, as you can see here in this picture, and they'll have sequential extension to those rods with smaller sequential interventions. The perioperative period is really important for neuromuscular scoliosis. When you have surgery, you get a 40% drop in your vital capacity because pain, atelectasis, and pain relief. And so a preoperative vital capacity of less than 60% is an indicator of an increased risk of prolonged postoperative ventilation. There are things you can do pre-op. You can manage their chest hygiene and optimize them, introduce them to mask ventilation that they'll need post-op if they're not already on it, and cough assist physiotherapy. And in the post-op situation, there are specific extubation protocols for neuromuscular children developed by John Bach in America, which incorporate effective cough assist and extubation to mask ventilation, and they reduce reintubation rates dramatically. I think the most important thing you can have for your hospital for spinal patients in neuromuscular disease is a respiratory care pathway, so that because these patients are looked after by many different spaces in that hospital, and they have complex technology and complex weaning strategies. We've had this at the Children's Hospital in Wales for 10 years now, and really we've had no respiratory complications that I can remember. Found it a very useful way of organising these patients' care as they pass through the hospital. Just quickly now on thoracic insufficiency syndromes. These are the congenital disorders of the chest wall and spine that cause respiratory distress. Threefold reasons: a mechanical compromise from abnormal ribs and scoliosis, persisting small volume thorax, and inadequate lung development and pulmonary hyperplasia. They're often severe, but not always, but they can present with respiratory failure, pulmonary hypertension, ventilator dependence, and their condition may be incompatible with life. Surgery is interesting. It's designed to try and increase the thoracic volume to potentially increase the lung growth. These are the sort of conditions you may recognize some of them. The short rib dysplasias with or without polydactyly, of which Jeune syndrome is probably the most common, and some of the severe congenital thoracic scolioses with bacterial syndrome and Charcot-Levine syndrome. I've also included Poland syndrome there, or Moebius-Poland syndrome as it's now called, because it's combined with Moebius. This is classically absence of the pectoralis major muscle and a limb defect on the ipsilateral side, but you can also have very large anterior rib defects in Poland syndrome and associated scoliosis and respiratory failure. So very interesting syndrome. The three approaches to chest expansion surgery are the sternal split, the lateral thoracic expansion, and the use of the Vector, the vertical expandable prosthetic titanium rib. As I say, I'm not a surgeon, but I've got some nice pictures here. This is the sternal split, pretty self-explanatory. The lateral thoracic expansion is an interesting operation. This is where two short ribs are cut asymmetrically and combined to form one longer rib, thereby expanding the thoracic cage laterally. So in the picture on the right-hand side there, you can see that rib 5 is cut long anteriorly and rib 6 is cut long posteriorly, and they're combined across 5 to 6 to form one long rib. And this work has been done at Great Ormond Street. That's probably pretty convincing before and after for lateral expansion, and a series of 9 patients that had this at Great Ormond Street, published in 2014, shows that 12 months after surgery, 12 were on nocturnal NIV, but off in the day. 2 were still on 24/7 invasive trachea ventilation, and there'd been 2 deaths. So mixed. The Vector, or vertical expanding prosthetic titanium rib, is a very flexible tool. As you can see, it can be connected between 2 ribs to expand the rib cage, as used in these pictures, but it can also be used fixed to a lumbar vertebrae or to the iliac crest. And so it's a very, very flexible way of manipulating the space, balancing a scoliosis or expanding a thoracic volume. And it's approved for treatment of thoracic insufficiency syndromes in pediatric patients, from fused ribs, scoliosis, absent ribs, hyperplastic thorax, but also for use in neuromuscular scoliosis without any rib abnormalities, and we sometimes see them in our neuromuscular patients. I'm going to stop there, a bit of a whistle-stop tour, but thank you very much.
Thank you very much, Julian. Excellent talk and an excellent overview of such a difficult subject. I've got a couple of questions here. The first is, and I'll slightly broaden that question, what is the role of physiotherapy in the management of this group of patients, and especially post-nurse procedure?
I guess the role of physiotherapy is very dependent on the underlying. So we use many different modalities for physiotherapy, and it's dependent principally, isn't it, on muscle strength and ability, glottal competence and ability to cough. So if you're using the NUS procedure for a pectus excavatum, then you should have somebody whose secretion clearance management is pretty normal, aside from the fact that they may have some pain, or they may have analgesia on board in the perioperative period. And then for that long period where they're immobile, they haven't got the mobility, which is also important in secretion management. So they will need to have some physiotherapy input, but I guess what they get is going to be dependent on what their underlying condition is.
Thank you. I'm not sure whether you were here yesterday morning, but yesterday Don presented an excellent case of using CPAT in patients with scoliosis and how it helped in the management with it. So Adnan has asked from, I think he's in Saudi, that what he wants to know is the CPAT data correlating with the radiological findings, and are there any reference values?
Yeah, I was here yesterday morning, and I did hear Don's case, and I've been involved with the orthopedic surgeons up in Edinburgh also. I think they're doing really great things with imaging. Some of the other things that have come out of James Farrell's work is, I think that Don showed the spinal intrusion, didn't he, and some compression of the bronchus intermedius also, and that can cause either collapse, which we see often, right lower lobe collapse, but also hyperinflation and the ball valve effect, and that's the basis to getting in lung function by re-recruitment of that space from the obstruction. And I think that's what that's where so he talked about getting people fitter, didn't he, for the surgery? But I think there's only in idiopathic scoliosis, there's only a small group of patients where their lung function is significantly compromised, and it's those that have a specific large spinal intrusion index. I don't know if there are any correlations between the visuals and the CPET, but I think Don was using it as a motivator, wasn't he, for getting fit pre-surgery.
Thank you. Couple of questions on Pectus excavatum. At what age do you personally refer the patient to the thoracic surgeon? And does the surgery has an impact on the lung function test?
So my own practice, and I tend to try and, so mostly it's a cosmetic issue, and my own clinical management is to try and delay this. Now that the NUS procedure can be done effectively in adult life, I think it's very important that that decision is not made immediately. So what I do is I see them, and usually they're referred, I don't know, maybe 10 or 11 or 12, and I talk to them about the procedures. I let them know in quite a lot of detail what it involves, and then I make arrangements to see them again in a year or two to rediscuss it. So I don't usually refer them when I first see them, and this is because we don't really have a timeline where we need to get this done, as adults can have this done equally safely. In terms of lung function, I don't think there's much effect on lung function from pectus excavatum surgery.
Thank you. And the final one, what investigations, if any, do you routinely perform in asymptomatic patients with Pectus? And does this vary with age?
So what I do for asymptomatic patients with mild pectus excavatum is I do a chest X-ray, because I'm interested to check that there's no underlying scoliosis abnormality, vertebral abnormality, and also want to look at the size of the lungs. So I'm interested in, especially if it's asymmetrical, I'd like to check that there's no pulmonary hyperplasia. But if it's asymptomatic and there are no signs of Marfan syndrome, there's no murmur, I would just do an X-ray to make sure that I understand what's going on with the vertebrae and the lungs, and lung function, of course.
Thank you very much, Julian. Thank you.